we're going to take a minute or two to let everyone join in, log in. So we'll get started in a moment. Okay, I think people will keep logging in, but I'm going to kick us off now. So thank you for joining us. My name is Lauren Stiles. I'm the president and founder of Dysautonomia International, and I'm really excited to be joined this evening by two outstanding autonomic researchers from the University of Calgary. Our first speaker is Dr. Jacquie Baker. Jacquie is a postdoctoral fellow at the University of Calgary. Her research uses clinical and preclinical approaches to study orthostatic hypotension and POTS with the goals of understanding the pathophysiology of the underlying autonomic disease and to test new and novel treatments to help improve the health outcomes for patients. So we're really, really glad to have Jacquie sort of joining this field. She's been in the field for a little while, but I think she's becoming more prominent in the research she's doing, and it's really great to see younger researchers trying to join the team. And our next speaker, I think probably a lot of you know, is Dr. Satish Raj. He's a member of our medical advisory board for a very long time. He's board certified in internal medicine, cardiology, clinical cardiac electrophysiology, and autonomic disorders. He spent over a decade studying POTS and other autonomic disorders at Vanderbilt's renowned Autonomic Dysfunction Center, but he moved back to Canada and where he came from, and he's now at the University of Calgary, where he's a professor of cardiac sciences and director of the Autonomic Investigation and Management Center, as well as the Cardiac Implantable Electrical Device Clinic. So he's also, are you the current president of the American Autonomic Society or the recent past president? I don't know if we have the updated bio.
Rapidly becoming the remote past president.
Okay, yeah. So he leads one of the largest physician societies for autonomic disorder doctors too. So the way we're gonna do this webinar this evening is first, Jacquie is gonna present on their new research, talking about what they found and what causes hyperventilation in POTS. And then Dr. Raj is going to join in and talk about some of the things we do to treat this in POTS patients. And at the end, assuming we have some time left before 8 p.m. Eastern, we'll take some questions from the audience. You can use any time during the webinar. You can use the Q&A tool at the bottom of your Zoom panel to type in a question. Just please try to keep your questions broadly applicable. The doctors can't answer specific medical questions about what your diagnosis is or what milligrams of a drug you should be taking. Try to keep it broad and on topic. And also keep in mind, we always get a lot more questions that we can possibly answer in one session. So please don't be upset with us if we don't get to your question. We'll try to get to as many as we can. So with that, I'm going to turn off my camera. I'm going to pass it over to Jacquie.
I'd just like to start by thanking Lauren for the opportunity for reaching out, for first off, I guess, reading her paper, and then reaching out to me and asking myself as well as Satish to be a part of this webinar this evening. So thank you very much, Lauren, for that. And today I'm going to be talking about sort of the mechanisms that we have been exploring in terms of what might be actually driving postural hyperventilation in patients with POTS. So I always just like to start a little bit broad and just sort of start by discussing just the autonomic nervous system. Sorry, I think my computer's being a bit delayed here. There we go. So I became extremely passionate about research when I was first introduced to what the autonomic nervous system is, but more importantly, what happens when it actually stops working. And when I'm talking with patients or when I'm talking to individuals who have never heard of this part of the nervous system, I refer to it as the automatic nervous system. And that's because it truly does control all of the things in our body that we simply do not have to think about, everything that should happen automatically. And when these automatic functions, things like breathing, digestion, bowel and bladder function become impaired, it can be quite devastating for individuals trying to live with this condition. And one of the areas I've been particularly invested in is understanding how impairments of the autonomic nervous system then go on to impact things like how the heart beats and how your body is able to regulate blood pressure. And within that realm, of course, we have postural tachycardia syndrome, or POTS. And I know I don't have to explain to this crowd, but this is a disorder of the autonomic nervous system that disproportionately affects females. And it is characterized by this excessive increase in heart rate when an individual stands up. And what's most important about this is that when we see these excessive changes in heart rate, there is no orthostatic hypotension. What that means is the blood pressure is not dropping. Because if the blood pressure was dropping, then this change in heart rate that we see would actually be normal and compensatory. But in POTS, we know that the blood pressure is actually not dropping, and therefore the tachycardia is truly excessive and exaggerated. And this also goes along with many chronic debilitating symptoms that are both cardiac as well as neurological. So anything from palpitations and chest pain all the way up to lightheadedness, blurred vision, brain fog. And over the last couple of years, I started to notice a lot more research coming out related to this phenomenon of postural hyperventilation that has been seen in some individuals with POTS. And part of the research that our group has been doing is actually trying to break down the individual components of postural hyperventilation. Of course, we have posture, but then we also see these changes in tidal volume. So when someone's hyperventilating, they can start to breathe much deeper. And then finally, as we continue to breathe deeper and deeper, we're actually blowing off the carbon dioxide or the CO2 in our body. And so that leads to something referred to as hypocapnia, or a low CO2 in our body. And we've been particularly interested in understanding each one of these components and how these may actually lead to a change or an exacerbation in the tachycardia that we see. And the reason this is particularly important is because as individuals are hyperventilating, are blowing off that CO2, what we actually know is that as CO2 is dropping, this actually causes the blood vessels in the brain to get smaller and smaller and smaller. Ultimately, what this translates to is this large reduction in brain blood flow. So not surprising, as the brain isn't receiving enough blood, individuals can start to experience things like a headache, blurred vision, and lightheadedness. The exact same symptoms that some of the patients report that they experienced. So it's because of this that we started to look into this. And what we actually found was that hypocapnia doesn't just make individuals have these symptoms. It actually significantly worsens the heart rate. So I'm just going to walk you through this slide here from this experiment that we did. But what we had patients do is they laid in the supine lying down position the entire time so that there was no confounding influence of posture on their heart rate. And what we had them do was breathe at the exact same rate and depth. And the only thing we let change as they were hyperventilating was how much CO2 was in their body. And what we found under these eukapnic conditions, which actually just means normal CO2 in the body, what we found is that as we let the amount of CO2 in their body go down from 37 to roughly 32, all the way down to around 20 millimeters of mercury, was this actually started to cause a very significant increase in an individual's heart rate. And again, this is while individuals were lying flat, so there's no influence of posture, and their breathing was the exact same. So what we're able to conclude from this was that just hypocapnia alone can actually significantly worsen heart rate. And it's not just heart rate. What we also found was that as patients were losing CO2 in their body, this caused this large reduction in stroke volume and also a large reduction in blood pressure. Two really important hemodynamic profiles, because it's under these conditions that the heart rate begins to work even harder to make sure that blood pressure actually doesn't fall anymore, or to try to bring stroke volume back up. So it's because of this hemodynamic profile, as well as the symptoms, that some literature has actually come out to say that this postural hyperventilation actually is the cause of POTS. Some research has even gone so far as to say that POTS actually isn't a cardiovascular disorder at all, but it's actually a respiratory disorder. But the main question that came out of this to me was, what is actually causing or driving this postural hyperventilation? And one of the, I guess, hypotheses that's been postulated in the literature has surrounded this idea of the peripheral chemoreflex, which I'm going to walk you through. So what the peripheral chemoreflex is we have this very specialized group of cells known as the carotid body that sit right at the bifurcation of the common carotid artery. And it's within this very specialized group of cells that the body is actually able to detect chemical changes in the blood. And when I say chemical changes, I mean changes in things like CO2 or carbon dioxide, oxygen, as well as the acidity of the blood. And when these chemical changes get out of balance, either CO2 is too high, which we refer to as hypercapnia, oxygen in the body is too low, which is hypoxia, or the blood becomes too acidic. This will actually excite or activate this chemoreflex. It'll excite these specialized cells within the carotid body. And when this happens, it sends signals back to the brainstem. And ultimately, this is just the body's attempts to regain balance, regain homeostasis. But what we see as an outcome is an increase in sympathetic nervous system activity, an increase in heart rate, blood pressure, as well as an increase in ventilation. Many of this hemodynamic profile that we also see in individuals with POTS. So it's because of this sort of input-output that some researchers have questioned whether or not this reflex is actually exaggerated. In other words, if those little carotid bodies, if those little sensors are actually too sensitive to changes, is it engaging this output, which is the increase in heart rate and ventilation? Is it driving this phenotype that we see in patients with POTS? And I found this a really interesting question. But what also really intrigued me was I knew exactly how we could test this question in our lab. Because when this came out, this was just simply a hypothesis that had been postulated with no real data to actually support it, in my opinion. But I thought we need to test it. And one of the ways that's been well established in research to shut off the carotid body, to turn off this reflex, is actually to just start breathing really, really high amounts of oxygen, something we refer to as hyperoxia. So on one side of the coin, where the very low oxygen will turn this reflex on, if you do the opposite, you can actually inhibit it and shut it off. And that's exactly what we set out to do. And so this has now been the current focus of my research interests, not only looking at the mechanisms that may be driving this postural hyperventilatory response, but then also using the results that we find to investigate new therapeutic approaches. There we are. Sorry about that. So the first question we set out to say, what exactly are the mechanisms of postural hyperventilation? And to do this, we did a randomized trial of hyperoxia. So again, that's that high oxygen compared to a normal oxygen condition. And we looked at the response in individuals with POTS as well as individuals without POTS. And how we tested this is we had individuals breathe what we call bouts, or short 30-second periods of really high oxygen, followed by 90 seconds of normal oxygen in between. And we repeated this 5 times. And while individuals were breathing this high oxygen, we were also measuring their breath by breath respiratory changes, so things like ventilation, oxygen, carbon dioxide, as well as their beat to beat hemodynamics. And we did this both in the lying down position as well as the upright position. So during a 60-degree head up tilt test. And I'm just going to briefly show you a representative trace to help everyone in the audience understand exactly what we were trying to look at. So in essence, if the carotid body was in fact exaggerated and we were able to completely shut it off, what we hypothesized is that we would see this reduction in ventilation, just like shutting off a light switch that's too bright. And we thought that if this response was actually even more on or even more excited, even more exaggerated in patients with POTS, when we shut it off, then this ventilatory change, this reduction, should be even greater in our POTS patient than in individuals without POTS. And so what we ended up finding, first we compared just changes going from the lying down position to the upright position. So just to orientate you to this graph, this is ventilation here. And we looked at supine ventilation, and we also looked at ventilation during head up tilt. And we compared our normal oxygen condition, the normoxia, to our high oxygen condition, or hyperoxia. And interestingly, what we actually found was that under both supine and head up tilt positions, when individuals started breathing high amounts of oxygen, their ventilation actually went down, both in the supine and the head up tilt position, indicating to us that whether or not individuals were supine or upright, there was a little bit of tonic activation of this chemoreflex, or that carotid body. What was actually really interesting that we didn't expect to find is that we did see a much more robust reduction in ventilation in the head up tilt position or the upright position compared to the lying down position. So that was really interesting, because what that said to us was that the carotid body actually was more activated in the upright position, which was exactly what some of those papers had postulated was to occur in individuals with POTS, that when they stand up, when blood all of a sudden isn't going to those carotid bodies, that this was actually going to trigger that sympathetic and ventilatory response. And so we did see a difference between supine and head up tilt, and that was really interesting. And we also found the same changes when we measured directly the sympathetic nervous system using microneurography. Again, we found that when individuals were breathing high oxygen, their sympathetic nervous system quieted, it decreased. And when we did this in the supine compared to the head up tilt position, there was a much greater reduction in the upright position. However, where our sort of hypothesis and story got off the rails is when we actually started comparing individuals with POTS compared to individuals without POTS. And even though it didn't go along with our hypothesis, what we actually found was that there was actually no difference whatsoever between patients with POTS and those without. In other words, both groups did have a little bit of inhibition in their ventilation, both in the supine and upright position, but it was identical, which means this reflex, in theory, is not exaggerated. We actually found the exact same thing in muscle sympathetic nerve activity. Yes, hyperoxia was able to inhibit the sympathetic nervous system, but it wasn't different between our groups. So when we circle back and ask the question, is the chemoreflex exaggerated? Based on our data, we concluded that actually, no, it's not. Because if it were, we should have seen differences between the two groups. But we still had a problem, because when we examined the cardiorespiratory changes, we still saw that individuals with POTS had a much more robust increase in heart rate when they stood up, and a much greater increase in their ventilatory response when they stood up. So something was still going on. It just wasn't related to the chemoreflex. And so we started to dig a little bit further into what other hemodynamic changes may have been occurring. And what we found was that in our patient cohort, in the upright position, in that first 90 seconds, as soon as we tilt patients up, we see that they have a much larger drop in not only in their stroke volume, but also in their brain blood flow. So something we refer to as their MCA, which is the middle cerebral artery, one of the main feeder arteries that goes to the brain. And we use something called the pulsatility index, which is actually a surrogate measure of perfusion. In other words, patients actually were experiencing a larger drop in brain perfusion compared to individuals without POTS. And what was really interesting was the relationships that we found. We found that for individuals that had a larger drop in stroke volume, this also meant that they had a larger drop in that brain perfusion index. And what was really interesting was that this translated further. In other words, individuals that had a larger drop in their brain perfusion Also, this predicted who was going to have a larger ventilatory response and whose sympathetic nervous system was going to become more activated or more engaged. And so now I'll take a step back. We recognize that these data, they're not causal. They are correlations. In other words, we can't directly say that this is causing that, at least not in humans. And so what we did was we turned more to our preclinical rodent model, where we actually can directly measure from the nerves and we can directly manipulate the amount of brain perfusion that's occurring in these animals. And so by using this preclinical model, we were able to directly take measures from the phrenic nerve, which we used as a measure of ventilation, and we were able to directly measure from the splanchnic nerve, which we use as our measure of sympathetic nervous system activity. And what we were able to do was, using a perfusion pump that we inserted up through the aorta, we were actually able to either decrease brain perfusion directly or increase it directly. And very interestingly, what we actually found was a direct relationship, not only in ventilation or phrenic nerve activity, but also in sympathetic nerve activity. In other words, as soon as we decreased the perfusion pressure, we see this robust increase in phrenic nerve activity. Again, an indicator of ventilation. And if we raise the perfusion pressure going to the brain, we see this quieting or lowering of phrenic nerve activity. Similarly, on the sympathetic side, we saw the same thing. When we reduced the brain perfusion here, you see this robust activation and firing of the sympathetic nervous system. Whereas if you raise brain perfusion, we get more of a quieting. This allowed us to make a more direct and sort of causal approach to understanding hyperventilation in POTS, because we were actually able to specifically manipulate brain perfusion in these animal models, something we can't do in humans. And so it was based on these findings that we proposed a new mechanism. When individuals with POTS stand up, we know that they can experience these large reductions in stroke volume. And we believe that that translates then to a reduction in brain perfusion. And when we see this reduction in brain perfusion, specifically within these key cardiorespiratory centers within the brainstem, we believe that that then indicates to send out these signals to increase phrenic nerve firing, or in other words, ventilation, and to increase sympathetic nerve activity. So what do we do about this then? That is the key question. Where do we target our what new therapeutic approaches should we take to target these proposed mechanisms? And one of the areas that Satish and I have been particularly invested in is looking at CO2 therapy, or carbon dioxide therapy, not only in individuals with POTS, but also individuals with orthostatic hypotension. And the reason for this is, if low CO2 and hypocapnia is so bad and worsens heart rate, makes patients feel horrible, reduces brain blood flow, then perhaps by reversing it and delivering CO2 back to the body, could we potentially reverse these deleterious effects that we see? And we know that carbon dioxide is actually a very powerful regulator of brain perfusion. It causes the brain blood vessels to all dilate, and it very powerfully increases brain blood flow. And so what we have been investigating is whether or not breathing extra CO2 could actually be a chemotherapy for patients with POTS. Now, these are preliminary data, but so far, what we have found, as we slowly increase the amount of CO2 that an individual is breathing, going from room air, or zero, which is where we just hold CO2 constant. We don't allow patients to stand up and have their CO2 drop. We hold it constant. Or we increase the amount of CO2 by 5 millimeters of mercury or 10 millimeters of mercury. What we've actually found is that this has caused a very nice, robust improvement in their standing stroke volume. We've also found that we've been able to completely reverse any drop in brain blood flow that we see, such that at the highest levels of CO2, we're increasing brain blood flow to nearly 30, it is velocity, so 30 centimeters per second. So a complete reversal and improvement in brain blood flow. Now, we are still exploring the specific heart rate data and other components related to this, including ventilation. So I'm not going to get too far into this because hopefully there'll be more exciting results to come in the future. But so far, we're really excited about this prospect of potentially using CO2 and delivering it back to patients to be able to reverse some of the hemodynamic and symptomatic changes that patients report. So with that, just checking my watch. Overall, we believe that inspired CO2 could actually have the potential to improve this hemodynamic instability that we see in patients. It certainly increases brain blood flow, and we're hopeful that this could potentially in turn decrease the excessive orthostatic tachycardia and the debilitating symptoms that many patients with POTS face. So with that said, just a few acknowledgements. My lab mates, my mentorship team, as well as all of our patients, as well as patient partners, and the funding bodies that allowed us to proceed with our work. And with that, thank you. And I will pass on to Dr. Satish Raj, who's going to discuss a little bit more on the therapeutic side.
Wonderful. Jackie, can you unshare?
Mm-hmm.
Let's see if we can. So with luck, you're seeing some slides now. Thank you for having me. Thanks to Lauren and all of you that are spending your evening with us. As Lauren said, my name is Satish Raj. I've been playing in this POTS pond for some time now, and I think some of the work Jackie's presented is really quite exciting. What Lauren wanted me to touch on, I guess, was something a little less cutting edge, perhaps, but maybe a bit more practical. So Jackie has talked about, as part of the work, some of the important role that stroke volume, which may be a surrogate measure for the amount of blood coming back to the heart, but that the important role that seems to play in driving both the tachycardia, but perhaps also changes in cerebral blood flow that may be contributing to a lot of the symptoms. So the question is, are there things that we can do about it? Now, if I were to ask that question to Jackie, she may start telling me all about what CO2 things that we could start trying to develop to do that. I'm not going to talk about that today. I'm going to leave that for Jackie a couple of years from now to come back and tell you sort of, how her work has further developed. What I'm going to focus on today is what we can do now. So up here, I just have disclosures. There's consulting for various groups. I guess I'll make 2 points about this. One, the amount of POTS consulting that's here didn't exist 5 years ago, right? So I bring this up because I think this is actually an exciting time. There's actually a lot of interest on the part of biotech companies, on the part of device companies that are interested in POTS and trying to develop tools to help us better understand it and to better treat it. And then one of the questions that's been submitted had to do with the Lumia device. And I would just point out that I have been consulting with them as well, although none of the data presented here was collected in the Lumia era, we'll say. So you guys all suffer this, but it's just worth understanding that standing up isn't actually a problem for a lot of people, but physiology plays a role in everyone. So when we stand up, blood shifts down, and this is purely a function of gravity, right? The effect of gravity on our blood vessels, comparing our head to our legs, is entirely different when we're lying flat versus when we're standing up and vertical, right? Now, in a normal, healthy, otherwise well person, the body's able to adapt to this change by squishing vessels here and there and trying to get more blood coming back to the point where, people feel fine, right? Most kids learn to get up and walk without complaining of orthostatic intolerance or lightheadedness, right? So this happens because of the autonomic nervous system. The changes are picked up and acted on in, micro to milliseconds, like really, really quickly, and we don't notice. Of course, everything's fine until things go wrong. So in patients with POTS, ultimately there isn't that proper adaptation, and the result is a series of symptoms that we think are contributed to significantly by issues related to inadequate blood getting back to the heart or blood pooling. Too many arrows. So years ago, in fact, this was related to the first project I did when I went down to Vanderbilt as a research fellow, postdoctoral research fellow back in the early 2000s. We were interested in trying to look at fluid shifts and to try and figure out if that was excessive in POTS patients, and that was the reason for the tachycardia. But one of the things we did is we actually measured absolute blood volume. And this is not an easy thing to do. The most labs, when you go and get your blood measured, it's all percentages or ratios. To measure absolute blood volume, pretty much requires a nuclear medicine test. And it is available in several hospitals in the US. It's actually not easily available in Canada, but we used a technique with using radio-labeled iodine, where you'd inject it and do sampling and then let it cook for a while and you'd get a number. And you could measure the plasma volume, the liquid part of blood. You could measure the red cell volume, the red cell part of blood, and you add them together, and that's the total blood volume. And what we found in this initial study is that, let me say one other thing, and that is that assessing the adequacy of blood volume is complicated because it's dependent on size and not in a fully linear way. It doesn't take a rocket scientist to figure out that Shaquille O'Neal and Simone Biles probably have a different amount of blood in them and probably need a different amount of blood. So what this method had included with it was an estimation of what the blood volume broken down by plasma volume, red cell volume, and total blood volume, what was needed for someone of that size and sex versus what was had. And then you could determine a deviation. Either you had too much of something or too little of something based on their estimates. And if you look at our healthy control groups, there's a spread of data in the black dots here, but on average, the mean value was that there was no deviation, right? The estimates actually worked out pretty well for that group. But if you look at the POTS patients shown here with the red dots, there was a deficit of about 12%. Now, in absolute volume, it wasn't a ton. It was about, somewhere between 250 and 300 milliliters. It was less than a can of Coke, right? But it turns out that relatively small volume, getting it in the right spot, actually, we think makes a big difference. So one issue is the amount of blood you have, like how full is the tank? But the other issue is, with gravity, with upright posture, where does the fluid go? And this slide was generated by colleagues at Vanderbilt many, many years ago using a technique called bioelectrical impedance, right? So it's a non-invasive technique, but you administer a small electrical current through a body, and then you can record using paired electrodes, resistance changes in the body, right? And, the big cause for resistance changes acutely, like in the span of minutes, is fluid shift, because fluid conducts electricity well, has low resistance. If fluid leaves, everything else has a higher resistance. And what you can see here is that in the chest or upper torso, in the chest area, when you tilt someone up, and this can be a patient or it can be a healthy person as well, the resistance goes up because there's less fluid in the chest. The fluid is leaving the chest. And everywhere below the chest, the resistance goes down, right? It goes down in the lower torso or abdomen, it goes down in the thigh, it goes down in the calf. That's the first thing to notice. The second thing to notice is where does the fluid go, or how much of the fluid goes to each location, right? So when we talk about compression, and when I am in clinic and I ask someone, have you used compression garments? The most common answer I get is yes, and they start telling me about socks or knee-high stockings. But if you look at the calf curve here, the amount of fluid that goes into your calf or the resistance drop in your calf is minimal, right? And it makes sense. Most people's calves aren't that big. You can't stick that much extra fluid in there just because of passive gravitational force. There's a little more in the thigh than in the calf, but the bulk of the fluid actually shifts from your chest to your abdomen and pelvis, or what was labeled here as lower torso, right? So this tells us not only that fluid shifts down, but it tells us where most of the fluid goes, and it's not your legs. So with that as a background, I'll just touch on the typical non-pharmacological treatment approaches we have for POTS, all of which are really focused on trying to get more blood back to the heart. So the first is dietary salt and water. And I'm sure you've all been told to take in more salt and drink more water. Historically, it still is a bit of a challenge, right? Because, the American Heart Association for years, and in Canada, the Heart and Stroke Association for years, has been ranting about the evils of dietary salt intake. Specifically too much dietary salt intake, but dietary salt intake. And it's worth trying to understand why. So from a public health point of view, the problem is not POTS. For individuals with POTS, the problem is POTS. But from a societal point of view, the much bigger problem is hypertension in middle age, and then the consequent risk of strokes, for example, in people with hypertension. So the American Heart Association and the Heart and Stroke Foundation are focused on trying to decrease hypertension in middle age. And part of that strategy, a big part of it, is restricting salt intake, right? But for POTS patients, not the right approach, right? The problem in POTS patients, we think, is too little blood volume, and we want to try to use dietary salt to fix that. So we actually did while people have been advising salt intake for years, actually until fairly recently, there was actually very poor data on what it did. But we actually did a study while I was still at Vanderbilt, latter part of my time at Vanderbilt, where we looked at the effect of dietary sodium intake. In salt, sodium chloride is the sodium we're most interested in. And we hypothesized that, retaining the salt would cause retention of fluid and expand the blood volume, that in turn would decrease the sympathetic activation that occurs when people stand up, right? And we could measure that by looking at the norepinephrine levels in the blood, that it would lower the standing heart rate, the heart rate in standing, but also lower the orthostatic tachycardia, that change in heart rate from lying to standing, and importantly, hope that it would improve symptoms. And so we did this study. It was a fairly difficult study. It involved bringing patients with POTS as well as sex and age match healthy control subjects into the research unit at Vanderbilt for 2 one-week stays. And the stays had to be about a month apart because all of the participants were female and premenopausal, and we wanted to make it around the same phase of the menstrual cycle because that can actually affect some of the things we're measuring. And during one of the phases, they were on a very low sodium diet, as low as we could make it. And during the other phase, they were on a very high sodium diet, and we randomized the order. And then they did the first, and whatever they didn't do the first time, they did the second time. And in that week, for most of the week, we did nothing. They did nothing but eat. We fed them, and we wanted to get them into steady state. But then at the end, after the 6 days, we figured they were in steady state in terms of their sodium levels, and we did a whole bunch of assessments. We formally looked at the blood volume, the plasma volume specifically, I think is what we're going to report. We did lying and standing studies, collecting blood work, among other things, for norepinephrine, again, a biochemical marker of sympathetic nervous system tone. And obviously, we tracked heart rates and blood pressures lying and standing. And what we found was that if you focus on the POTS patients in red first, that the blood volume deficits that we saw decreased, right? This is total blood volume. This is the overall blood volume. So the blood volume increased. It actually increased in both POTS, and if you look at the healthy control subjects in blue, it increased in both. But the healthy control subjects started off with pretty much expected blood volume, and it went to supernormal. The POTS patient started with a deficit, and it went to less of a deficit, right? But so it didn't make everything all better, but it improved things. When broken down into the components, I'm actually going to get you to look at the right side, the right panel first. If you look at the red cell volume, the red blood cell volume, it didn't change it at all. And that's not surprising. The salt is targeting the plasma portion of blood, the liquid part of blood. It's not targeting the red cells. Now, it's possible if we did this study for a longer period of time, instead of 1 week, if we had done this for a few months, it's possible we'd see changes, but that's just speculation. But if you focus on the left-hand side and focus on the plasma volume, the liquid part of blood, the deficit that the POTS patients had almost completely went away, right? We fully normalized the deficit going from the low sodium to the high sodium diet. Again, the healthy control subjects in blue went from normal, in this case, maybe they had a slight excess based on the math, the estimates, to supernormal, right? So the POTS patients at the end didn't look fully like didn't look like the healthy control subjects fully, but they certainly improved in the measures that we were trying to improve. We looked at the upright plasma norepinephrine level, right? So a marker of sympathetic nervous system tone. And you can see the POTS patients had very high levels on the low sodium diet, and it decreased on the high sodium diet. It was still high. I mean, 750 as an average value, just to be clear, is not normal. It's still elevated, but it did come down a lot. The healthy control subject came down a bit, but they started normal and they went to lower normal. I'm going to stay on this slide for just one moment and get you to look at the POTS patient data again. So one of the questions I sometimes get asked is something along the lines of, I have hyperadrenergic POTS. Should I still take salt? Now, I'm not going to get into the whole issue of whether we should be labeling people with hyperadrenergic POTS or not. That's, a rant for a different day. But let's assume everything that was said was true. A norepinephrine level of 1,000 on standing is hyperadrenergic, whether we want to label the POTS hyperadrenergic or not, but it's certainly a hyperadrenergic feature. And we improved things. Okay, so it's not, as simple as saying, well, I already have, my pressures already goes up at times, I'm revved up, I shouldn't take more salt. If that's happening as a response, as a reflex to a low blood volume, then increasing the blood volume by increasing your dietary salt intake can actually help reverse that a bit. We looked at heart rates. You can see there wasn't much difference when patients were lying down. When patients were upright, their heart rates were lower on the high salt diet, whether they were POTS patients in red or the healthy control subjects. Actually, I think this is black instead of blue. I think I messed up the colors a bit. And the delta heart rates, which is the difference between the upright and the supine, were also decreased significantly and decreased significantly. Again, worth noting, still not to the levels of the healthy control subject. So it's not to say that the treatment of POTS is all about take more salt, but it certainly did seem to help. And symptom burden, we didn't actually get symptom reports back from everyone. So, so the power statistically of this analysis is a little less. But you can see here, if you look at the individual patient data, that the symptom burden in those that we have data seem to decrease a fair bit on the high sodium diet day compared to the low sodium diet day, while the control subjects weren't that symptomatic on either day, and certainly there was no apparent benefit in the healthy controls. Okay, so let me summarize that by saying that in POTS patients, the high salt diet increased plasma volume. It decreased the standing norepinephrine levels, which is a measure of sympathetic nervous system tone, and it decreased the orthostatic tachycardia, or the amount of heart rate increase on standing. But it didn't fix a POTS patient. It didn't make them, like a healthy control subject, never thought about the POTS again. It made things better. It didn't make things totally better. Okay, and this graphically is sort of summarized here that on a low salt diet, there's less blood, or in this case, water in the tub. On the high salt diet, that increased. With the higher salt diet, the norepinephrine level doesn't go as much on standing, and the heart rate on standing is lower. Okay, so that's all well and good. We had a metabolic kitchen making food that was, I don't know if it was yummy, but at least tolerable. Most people don't have that. So from a clinic point of view, this is actually my approach. I try and get patients to target at least 3 liters of water per day. Realistically, it's a lot. It's doable. Realistically, it works best if people have a dedicated water bottle, right? I want this water bottle with patients all the time. I tell patients that if there's a family photo, I want the water bottle in it because it really want to be a part of that. In addition to that, we want patients to take in about 10 grams of salt per day. That's sort of the number that both the Heart Rhythm Society position statement from 2015 and the more recent Canadian Cardiovascular Society statement used. The truth is the data for the exact number isn't great, saying this number is better than that, but it's the number we use. Now, the problem is that's hard. The math is hard. It's hard for me to sit and count up the amount of sodium or salt from here or there and say, this is what you have. So the approach I use is what I call the teaspoon or the Ziploc bag method, or the teaspoon approach. So basically you take 2 teaspoons of salt. Each teaspoon of salt is about 5 grams. So 2 teaspoons is about 10 grams. Put it in a Ziploc snack bag or a Glad snack bag or any other container you have in the morning. And instead of shaking salt, into your food and taking it from different sources, take it from this bag. So that way you know roughly how much salt you're getting in. Most of my patients like the taste of salt, and adding it to food is the cheapest and often the best tolerated way of getting it in. Some people hate the taste of salt and they won't eat the food if you add the salt. It's totally unpalatable. And that's fine. In that case, it's up to the patient to find what works. So some people add it to their water bottles and drink salt water all the time, their own sort of low budget electrolyte drink. Some people do saltwater shots, typically younger patients. It's, a third of a teaspoon of salt in a shot glass with some water. It's like a margarita without the, alcohol. So maybe without the good stuff, but, ultimately it doesn't matter how it gets in. Patients have to find what works for them. I don't tend to use salt tablets very often. I prefer diet approaches. If the diet doesn't work, then salt tablets could be used. The problem with regular salt tablets is that I find it causes more nausea than dietary salt. Not too expensive, more expensive than, granulated salt, but not too bad. There are coated tablets. Vitacium is one. I'm sure there are others that are better tolerated. Very few patients tell me they don't tolerate this. There are some, but it's the exception. The problem is if you're trying to get in 10 grams of salt per day with things like Vitacium, it gets fairly expensive, and that's the challenge with these approaches. Okay, so moving on from salt and water, what about compression garments? So I've alluded to them already. I'm a big fan of compression garments. And the principle here is that fluid shifts, as I showed you in that early graph with the electrical impedance. And the question is, can we mitigate that shift? Can we decrease the amount of that shift? And so Kate Bourne, who recently defended her PhD in our lab, did a study a few years back with a segmental compression garment device, if you will, where we could compress just the legs, which is sort of like calf compression. We could compress, the abdomen and pelvis and upper thigh, which is sort of a bicycle short compression. And then we could do a full compression of abdomen all the way down to the legs versus no compression. So we had patients and we put them through 4 tilt tests in one day in each of these configurations, and we randomized the order. And if you focus on the primary comparison with no compression versus compression, you can see here that with full compression in lavender, I guess, light purple, compared to the no compression in blue, there was a significant decrease in the upright heart rate. It didn't go up as much initially, and then, with no compression, there was an ongoing drift up in the heart rate over 10 minutes on upright tilt that was mitigated with full compression. But as I mentioned, Kate didn't just do full versus none. She looked at segmental compressions, the bicycle shorts and the calf only. Or sorry, the bicycle shorts, is the abdominal in green, and the calf only, the leg in red. And basically what we found is that there is a dose-dependent relationship, if you will. The more compression, the better. But the abdominal compression provided the vast majority of the benefit of full compression, while the leg compression alone was marginally better than none, but not a lot better than none. It decreased the heart rate on standing, the increase in heart rate on standing. It decreased the drop in blood pressure. And I want to just discuss that for a moment. So if you look with no compression, the blood pressure fell about 10 millimeters of mercury. Now, officially, this isn't orthostatic hypotension because a diagnosis of orthostatic hypotension requires a drop of at least 20 millimeters of mercury in systolic blood pressure, right? But certainly it suggests the blood pressure is a bit soft. And I suspect that, this compression, decreasing that actually is part of the benefits that we're seeing. If you focus on the bottom left panel here, it looks at stroke volume. Jacquie talked about stroke volume and its effects, and stroke volume is a measure of how much blood comes out of the heart with every beat. It's probably our best measure right now of how much blood is going into the heart for every beat. And I think that's what we're affecting. But you can see with full compression and abdominal compression, the purple and the green here, there is a significant decrease in the decrease, if you will, of stroke volume. So the stroke volume doesn't fall as much as with no compression when you go from lying down to tilted up, which similarly lying down to standing. So all of what I've shown you up to now is our physiologic parameters, and Jackie and I are human physiologists at heart, so that's great. But most patients don't care too much about that. They want to feel better. And so we did look at symptoms. We used the Vanderbilt Orthostatic Symptom Score, and you can see in a dose-dependent way that the more compression we had, the lower the symptom burden. So in the VOS, lower scores are better, higher scores mean more symptoms and feeling worse. And so the compression worked in a dose-dependent manner. And there was actually a very tight correlation between the symptom score and the change in heart rate. So the more we were able to blunt that increase in heart rate, the more we were able to improve symptoms in these patients. So that's great. That was a lab study, it was a proof of concept. But you know, the garment that we used was made of neoprene and Velcro. There's absolutely no one on earth, who would consider wearing this on a day-to-day basis. It was butt ugly. So the question was, do commercial compression garments, do things that we either prescribe or more commonly even tell people to go to sporting goods store and purchase, either that or on Amazon, do they work? And so Kate has done a follow-up study. It's in review right now. So manuscripts have been submitted looking at compression with commercial garments. And we actually had a monitor, a Holter monitor to record heart rate with instructions that we sent to people's homes. So this was actually a COVID-friendly study. And what we found in our protocol is that we get people to do 10-minute orthostatic vitals in the morning, put the compression garment on, wait 30 minutes and do it again. And you can see that, with and without compression, the supine heart rate wasn't that different, but with compression, the standing heart rate decreased significantly. Now, we asked them to keep the garment on for at least 3 or 4 hours, and in the afternoon, do the same thing in reverse. So before taking off the garment, do a 10-minute set of orthostatic vitals, take off the garment, wait 30 minutes and assess it again. And again, even in the afternoon, there was a significant benefit from wearing that garment. So the benefit of the garment isn't just when you put it on, it actually lasts for several hours. It is worth noting, I'm not sure we're going to show this in the next slide, maybe not. It is worth noting if you look carefully at the purple stand on the far right and the red stand in the left panel, that the numbers do look to be a bit different. So, compare the purple stand. So this is no garment to the blue no garment in the morning. It's actually a little better in the afternoon. So the heart rate without the garment in the morning is higher than the heart rate without the garment in the afternoon. And that reflects physiology. So there's a diurnal variation in the heart rate on standing. So heart rates on standing just physiologically are higher in the morning than they are later in the day. Certainly in the afternoon, but the change probably occurs in the mid to late morning. And that has implications, if you're trying to assess your heart rates for your doctor, when you do it does make a difference. So this slide just takes the data from the other slides and melts it into the delta heart rate or the orthostatic tachycardia. And you can see, it was almost 40 beats per minute was the increase without compression. And you put the compression on and you were about 25. So you went below that magical 30 beat per minute number that we made up. And in reverse again, you can see the delta heart rate not that different. The red and the green not that different with compression on. But if you take the compression off, it's a little better in the afternoon without compression than in the morning without compression. And similarly, symptoms improved. Symptoms were better with the compression on in the morning, and symptoms got worse when you took the compression off in the afternoon. So I'm going to just finish with a few words about exercise. This is the other key pillar of non-pharmacological training. This is something that I think historically had always been recommended, but realistically, patients would tell us they weren't able to do it. And there was always a question whether it made a difference or not. There was anecdote that patients that exercise seemed to do better, but there, was that selection bias? Was that just the people that could exercise weren't as sick, and so that's why they looked like they were better? What changed in the 2000s was there were a few studies, the best one probably out of Dallas, but a study out of Vienna, a study out of Mayo that actually looked at the effects of exercise training and showed benefit. This was a slide from the Dallas study. They did a 3 to 6 month, took POTS patients and put them through a 3 to 6 month exercise program. They measured a gazillion things. It was, from a physiologist point of view, they measured just about everything, not everything, but they looked at cardiac MRIs to look at heart size. They did ultrasounds of the heart. They put catheters in and measured pressures. They put needles in the nerve to measure nerve activity. They did the typical lying and standing tests that we do in clinic and the blood work that I talked about in the SALT study. They did all that. And what they found is that, everyone that completed the protocol, which, to be fair, is not the same as everyone that started it, that everyone that completed this 3 to 6 month protocol, had an increase in fitness levels, okay, increased their blood volume, right? So that's one of the things that exercise does, that it alters the hormonal ratios that occur, including hormones like aldosterone that promote sodium retention. So it does some of the stuff we were trying to do in that first blood volume study. It caused the cardiac mass to increase, or cardiac remodeling. It decreased the excess nerve activity in sympathetic nerves. Again, all of this is physiology. It excites me. Most patients don't get too excited by this. Some do. It decreased the orthostatic tachycardia, right? So this is something that patients can measure themselves. And they had everyone rate their quality of life using a simple tool called the SF-36. It's a very commonly used tool. And again, everyone improved a bit. So how to do it? There are calendars out there. If you're a calendar person, quite frankly, I don't understand the calendars. They speak exercise physiology. So I don't use them. I try and give my patients the underlying principles, and everyone follows some form of what's called the modified Levine protocol. The interesting thing is there are lots of different modifications to the Levine protocol. There's the CHOP one, which I think is on the DI website. Our approach is a tiny bit different. What we have focused on is trying to get people exercising not at a high load, like drop the load, make it as easy as possible, but try and get the frequency and duration down and then build up everything afterwards. So the focus is mainly on aerobic training. We try to get people to exercise regularly, so at least every other day or 4 times a week for 30-minute sessions. Extensions of time can come later, but the most important thing was, if someone feels really crappy standing up early on, don't ask them to do exercise standing up. So initially, upright exercises are forbidden because of tolerability, not because they're bad. And so we recommend the use of a rowing machine or a recumbent cycle. Swimming is also probably quite reasonable. The reality is that the study was originally done in Dallas, where I think every other person has an outdoor pool. I live in Calgary. We call outdoor pools ice rinks up here. So access to swimming pools not as good, right? So I don't tend to use that as much, but it's an option. We tend to use recumbent cycles and rowing machines. And the nice thing about both of these are that there's a dial that can make it harder or easier. I encourage my patients to turn it all the way down, make it as easy as possible, right? And then if they still have trouble getting to the 30 minutes, let's say at 7 minutes, they feel like they're about to die, they should stop, right? But if they actually, are sort of done at 7 minutes, what that means is they went out too quickly for what they're able to do. So the next time they go out, they should go out more slowly. Go out as slowly as you need to get to that time. And there is a speed at which you can do that. The other thing it's worth keeping in mind is it can take up to 6 weeks, a long time, before you start to see benefits. And in that time, the patients can often feel worse. So it took me in the beginning when I started this, I didn't realize this. And so patients would come back and say it didn't work because they tried for 2 or 3 weeks and saw no benefit. And I had to reach out to Chi Fu, who led the study, and say, what am I doing wrong? And she said, we said people got better. We didn't say when, right? And it was a 3 to 6 month study. And so we've been doing this now for 10 or 15 years. And certainly it is true that people get better, but it can take a while. Okay, so with that, the keys of non-pharmacological treatments, all at some level focused on getting more blood back to the heart and increasing stroke volume, or increasing your dietary salt intake, compression garments, but compression focused on the abdomen and pelvis, and exercise training with a focus on aerobic reconditioning, not necessarily other things. And with that, I thank you for your attention.
Thank you so much, Satish, and sorry, Dr. Raj and Dr. Baker. So you guys were great and answered a lot of questions during the chat, which we very much appreciate. If anyone hasn't seen it, you can check out the answered questions in the Q&A tool. They are visible to other participants. You can also check out in the chat tool at the bottom of the Zoom, I put a bunch of links to Dysautonomia International resources and to their research paper, if anybody wants to check those out. So we got a few questions we haven't answered here, and some of them have like a theme. There's a bunch of people who've asked the same thing. So I'm going to ask you these. And the first question I'm going to ask, you did address it during your talk, Dr. Raj, but I think because it was asked by so many people, I think it's worth kind of just reviewing the response again. So there's several questions about if you have high blood pressure, should you still take salt and if you have POTS? And specifically, someone's asking if you are a postmenopausal woman with high blood pressure. So, are there situations where you wouldn't advise salt for POTS?
So, so I guess the question, if someone has high blood pressure, is when is it high, right? So are we talking about someone who has normal or sometimes even low pressure, but at times of stress or at certain times the pressure goes very high? Or are we talking about someone whose pressure is always high? So what I would say is if someone's, that's the first thing. The second thing is blood pressure is a chronic problem, not an acute problem, right? So I would avoid overreacting to one or two blood pressures. But if someone has been measuring their blood pressures the right way after thinking, warm, nice, relaxing thoughts over and over again, and after weeks of assessment, the pressure is always, say, 150 for the top number, the systolic blood pressure, then I think, it may be worth reconsidering the salt advice then. But I will say that's incredibly uncommon in the POTS patients that I see, that the pressure is chronically elevated all the time. When people come to tell me they have high blood pressure, often it's, normal, and then at times it's high, especially under stress, which it turns out is when they measure it because they feel like crap and they're going, I wonder why, and they measure their pressure, right? But if they're actually measuring it more systemically, it's not usually as high all the time.
Feeling like crap is my favorite scientific term for what this is. Um, and we had a lot of questions also. I think this is a challenging clinical and research question that we definitely need more research on to get a clear answer, but certainly a controversial topic in our patient community. So if you have been diagnosed with chronic fatigue syndrome and you have post-exertional malaise, and you've been diagnosed with POTS, in the ME/CFS community, there's sort of a lot of concern about exercise as something that can make people feel a lot worse. And in POTS, we have all this advice to exercise. So when you have a patient that's diagnosed with both of those things, how do you kind of walk that line?
So, I mean, it's worth noting that when you try and Vanderbilt at one point, let me take a step back. So the diagnosis of chronic fatigue syndrome isn't as straightforward as it might seem. So if you, go over the last 20 or 25 years, the criteria, there are multiple criteria and it's changed and evolved. So keeping that in mind, using criteria from around, 2010, my time at Vanderbilt, we actually assessed chronic fatigue syndrome against the criteria of the time, which was CDC criteria, the Fukuda criteria at the time. And we found about 60% of the POTS patients that were coming to the research unit at Vanderbilt that we studied in depth that definitely had POTS met criteria. So there's clearly a strong overlap and you can collect the labels. But obviously there are a lot of patients with chronic fatigue syndrome that don't meet POTS criteria, that some of whom have very little to no tachycardia. So it's not even that they just missed the bar, it's that they weren't even close, right? It's a totally different thing. And so that's one of the challenges. Both of these are syndromic disorders and there are different things feeding in, but chronic fatigue syndrome has people with high heart rates and people with low heart rates. And obviously heart rate strategies that we're trying to target the heart rate changes may not be the same or make as much sense. So what I will say is that in the tachycardia group, right? So of the people that meet criteria for POTS, we have data that it can be helpful. Exercise can be helpful. In the chronic fatigue syndrome group, there are some exercise studies. There's one that was done in England that is often criticized in the chronic fatigue community, that suggested that that graded exercise was helpful or graded exercise therapy or GET was helpful, and it's been challenged as to whether there were methodological problems. But even if you discount that, if you accept all of the challenges that it wasn't done properly, that's data, that's the absence of data that is helpful in the group without tachycardia. It's not data that is harmful. What is absolutely true is that a lot of patients, including those with tachycardia, have post-exertional malaise, right? That they feel worse, shitty, can't get out of bed for a couple of days when they exercise. I will tell you, this isn't published experience, but in 15 years of doing this, I've had patients that have trained out of that, right? Now, is that everyone? No. So probably not everyone, can do it. There are different challenges to doing these things, but the point is it can be done. So I would be wary about saying, well, someone said I have this, so I shouldn't exercise. Because my question that has never been adequately answered is, okay, then what? Right? Because usually when people are coming to see me, it's because they feel horrible and they don't like how they're feeling. If someone felt like, I'm where I am is okay, I function at a level that I'm okay with, and if this is the way I'm going to be for the next 30 years or 40 years of my life, I'm good with that, then maybe it's not worth taking the risk, right? But usually when people are coming to see me, it's, I feel miserable. Is there anything that can be done? And that's where I think exercise comes in. And it's not just, a random doctor suggesting it. I mean, the truth is there are lots of patients that have gone through this. I mean, POTS is still relatively young as a disorder, but it's not so young that we have no experience with it. There are people that have gone through it and people that have benefited and people, not in an abstract sense, people that are still benefiting because you have to keep doing it to continue to see the benefits.
I think one of the real challenges with this is when we say the word exercise, it's such a like a lightning word, like because for POTS patients and for ME/CFS patients, we're often, before we find a doctor that knows what they're doing with these patients, we often encounter doctors that just blame us for the illness, right? They say, oh, it's your fault, you're out of shape, you're deconditioned, you're fat, whatever. You're just anxious. There's all this kind of gaslighting that happens. And they often sort of put it on, it's just deconditioning, you just need to exercise. And so there's a natural sort of anger or being pissed off when you're told that, because as a person, like, no, I was fine like 3 months ago and now I'm like bedridden. This is not, So I wish our patient communities and the researchers could kind of take a step back from the word exercise and say, what do we actually mean by that, right? Because exercise for Simone Biles, did I say Simone Biles? That's brain fog. Exercise for her is very different than exercise for me that my body needs, And so I really wish we could just think about it as physical activity that's appropriate for your body and your health situation, and not kind of get stuck into the idea that like you have to be running on a treadmill sweating to be getting exercise, because I don't think that's what exercise means.
And we specifically probably don't want you running on a treadmill.
Definitely don't
Just
want to be
because treadmills are upright, right? I mean, the flip side is there's some patients that are doing it and can do it, and I have no problem if they can do it. But most of our patients can do 3 good minutes on a treadmill.
Right.
And it's better to get, longer periods of time where you're not, letting gravity do its thing
Yeah.
as much.
I mean, I have gone through the stage of being completely bedridden with POTS before I was properly diagnosed and treated, and having to recondition my body from that bedridden state to just being a functional human being that could like make myself a sandwich in the kitchen was the hardest thing I ever had to do in my life. It was really, really freaking hard. And it was a long time to do a lot of not a linear improvement, like feeling better, feeling worse, feeling better, feeling worse. And then eventually was able to get back to things like surfing and snowboarding, not at the way I used to do it, but at least, when you've been bedridden for a few years, you're excited if you could go to the grocery store. So I think that question always comes up in our support groups because there is an overlap and there seems to be sort of contradictory philosophical approaches. I just listened to a lecture from Peter Rowe, who's a really, you know him and have worked with him. He's a really respected ME/CFS researcher. And he actually talked in his lecture about the importance of exercise and physical activity, but not pushing yourself beyond your limits, not going in a regimented, you must do an hour a day, 6 days a week, and then improve to 2 hours next week. Like a structured graded exercise therapy seems to be too much for a lot of these patients. And going at your own pace that is actually doable for you and tolerable is, I think, consistency in getting some physical activity is more important than intense aerobic activity, especially when you're in that really not well-functioning state, you know?
There's one other thing that you said, I think that's important to highlight, and that is that, everyone wants improvement, right? And we think of improvement as, this line going straight up to the sky, right? And if you stand far enough back, maybe that would, some people might achieve that. But if you look closely, it's never like, straight up, right? It's, I don't know if the people on the call on the webinar are too young to remember playing snakes and ladders, but when I was a kid, we played snakes and ladders, but that's basically the course. You go up and you have little setbacks and up. What you want is the overall trend to be up. But if you might be worse than you were last week. That doesn't mean the world has, the sky has fallen in and it's caved. That's actually the norm, to have little setbacks. But the key is just to keep plugging and then hopefully having improvements going forward over time.
I'm wondering if snakes and ladders is a Canadian thing. In the US, it's shoots and ladders, but maybe there's like different versions of it. So anyways, we're over time, but that's because you guys did such a great presentation. There's so many great questions here. We'll try to get some of them answered. Like before we hang up, but I just wanted to thank you both for your time and the research you're doing. And I want everyone on the call, the patients listening in, to know, like, it doesn't feel like it on the day-to-day when you're really suffering with a health problem, but there's so much progress being made in POTS right now, and more, dysautonomias, we've been around for 12 years. I've been part of this patient community for 14 years, and there's more interest in advancing POTS and other dysautonomia research right now than ever in history. And so I have hope that there's going to be more physiology understanding, like this paper about different parts of what POTS is doing to us, more treatable targets, more pharma investment in developing new treatments, and not just pharma investment. I think it's not just about pharma. There's certainly other things, devices, supplements, non-pharma type treatments. So I would say everybody remain hopeful, even when it's really hard to do that. Just a couple things I want to plug before we go. We have, if anybody didn't check out our 2024 conference in person or live streamed, we have, you can access all the recordings, 25 or more lectures from the 2024 conference, which was held in June in Chicago, or sorry, July in Chicago. No, June, end of June, sorry. And those are available at dysconf.org, dysconf.org. There's a $25 fee to access them, but it's because it costs us a fortune to make all the recordings and fly in all the doctors for the lectures, which they all volunteer their time, just so everybody knows that. We also have upcoming the Detroit POTS Walk and the Boston POTS Walk this fall. And if anybody's out there from a different city and wants to do another one, let us know. We'd love to work with you. Maybe we need to get one set up in Calgary. The cool thing about the POTS Walk is there's actually no running or walking involved, because we know that not all of us are up for that. There's a lot of families that just come out for the day to show their support. There's people who participate virtually if they're unable to come in person. And it's just kind of a great thing. And all the funds raised go to funding POTS research. We have Dysautonomia Awareness Month coming up in October. So that's a great way to, a great time of year to sort of share your POTS experience or your dysautonomia experience with your family and friends, and host, we have Facebook fundraisers happening. We'll have a lot of in-person community events, lightings. We have like hundreds of buildings being lit up. We'll be posting the list on our social media and website soon. So there's probably over 300 events happening around the US and around the world. And then October 5th, we have a patient and physician education day at Stony Brook University in New York, which we will have a live stream version of if you can't come in person to join us. So let your doctors know about that too, because that will be a clinician education course, try to help get more doctors comfortable working with our patient community and knowing actually what to do for us, which would be great. And that's it. I just want to thank you guys again for your good work. And thanks for everybody for joining us this evening and all your great questions. Any last thoughts?
Keep up the hope.
Yes.
Thanks again, Lauren. Appreciate the invite.
Thanks so much. Bye.
Okay.